I'm Kelly Grimes. I'm from the Canadian Health Leadership Network, better known as WHLNet. We're co-hosting this webinar along with the World Health Leadership Network. We want to begin by respectfully acknowledging we're hosting today from Canada, a country we love, on the traditional territories and ancestral lands of the Indigenous, Métis, and Inuit peoples of Turtle Island. I invite you to take a moment to reflect on the lands from which you are participating from around the world and pay respect to the earth that nourishes life. Let us reaffirm our commitment to forging culturally safe, inclusive, and respectful relationships in our pathways towards reconciliation and the betterment of the planet and its peoples. Please also join me acknowledging the Indigenous culture of knowledge sharing that leverages collective experiences and allows people to learn from one another in a safe and trust-filled dialogue. It's in that spirit of mutual respect and collaboration that we come together today. So if you're new to this collaborative experience, the World Health Leadership Network is a concept born from the experiences of the Canadian Health Leadership Network, a network that began 15 years ago. A guiding coalition of the willings been working hard on this to operationalize the world version on an international scale. Many of the individuals are on this webinar today, so thanks to you all, especially in these times of turbulence and upheaval across the world. The importance of coming together to better our planet and the health leaders has never been more important.
Thanks to all of you for joining us here today on our first of 2025 WHL broadcast. And as Graham's indicated, it's around the theme of leading in the current socio-political environment. As Graham said, I'm Bill Thal, and I'm happy to be your moderator for today. And I want to bring greetings from the great white North Canada, ever strong and still free. I'm pleased, as I say, to be your moderator today. My job is to kind of keep us on time, stick to sort of the themes. Graham's already described sort of the basic lineup for today, so I'll shortly introduce our three speakers in succession. There were two pre-reads circulated in advance to help set the stage for today. A JAMA article contemplates a world without the WHO, raising the prospect of the United States pulling out. I would just flag the fact that President Trump has indeed signed an executive order giving the one-year notice required that the United States will be pulling out, with all the potential consequences set out in that JAMA article. The second article reports out on an NHS study, or a study of NHS leaders, focusing on the leadership skills required to navigate both big P, macro level policy issues or political issues, and smaller p, micro level politics, policies and practices. For those of you that might not have had a chance to read both, our intrepid coordinator, WHL coordinator, Kirsten, who I believe is on the call, prepared a one-page briefing note that kind of summarizes what you need to know going into our discussions. So with that, Graham's already explained, and I'll just repeat very briefly that we'll have three speakers. Each will be given 8 to 10 minutes. I would encourage all of you to, if you have any questions of clarification or questions in general of the three speakers as we go along, please put them in the chat box. Grace and I will kind of monitor those and bring those back, time permitting, after each of the three speakers speak. They will each be given 8 to 10 minutes. And again, have been asked to address the two questions. What challenges from perspective of large P or small p politics do you face in your role as health leader, or that you see as an observer of the health leadership today, health leadership environment today? And question number two, what leadership attributes are required to deal with these challenges, and what would you like to learn about them? So first up is Dr. Mike Durkin, who currently serves as a senior advisor on patient safety and policy and leadership at the Institute of Global Health, Global Health Innovation. Mike's impressive bio is in the chat box, right, Grace? Perfect. He will be sharing a UK perspective on navigating the socio-political environment. And so with that, over to you, Mike. Welcome your comments and your presentation.
Thank you very much, Bill. Thank you. And also thank you, Graham, Grace, and everyone else. And who's behind this webinar and working hard on it, in particular, I guess, Kirsten as well, who it's many years since I've worked with Kirsten, but it was very good then and it will be now. What I'd like to do is to set in place a series of elements that I think are important for us to use when we as clinical or medical or healthcare leaders are trying to introduce change, which inevitably should be linked to improvement in various political scenarios. And what I'm going to try and do is to link what is some of our basic frameworks for action with the highlights that came from Justin Waring's paper, which for those of you who haven't had a chance to read it, it's a really good treatise on the thinking certainly 2 or 3 years ago. And then I want to give you 2 or 3 examples of how in my work some of these elements have been quite important for me to follow. So where are we now and where have we been? Well, to understand where we are now and why we are in some places in a bit of a pickle because of the rather inadvertently shifting sands within the political firmament in every continent, not just in the North American continent, but everywhere. So what are our reference points then for this work? I'd like to go back to 1999. So the initial element that came out of the Institute of Medicine's work on what is it important to healthcare professionals and healthcare systems when they're looking to introduce change and quality improvement in their elements. And this was a great piece of work initially set off by Lucian Leap, Don Berwick, Paul Batalden and others, and working to identify key elements and then a framework. What people often forget when if they haven't gone through to Ur is Human, it identified 6 key elements of a quality system in healthcare, but what it also did was to key actions and frameworks. People have often forgotten the frameworks that they were introducing. Anyway, the 3 key things that we have to hold dear as leaders in trying to introduce political change: quality, safety, effectiveness, timeliness, efficiency, equity, and person-centered elements. Now, I think they're all very laudable and 6 aspects. They're there. We know they're there. They don't necessarily pull at the heartstrings of politicians when you're trying to change or influence, both small p and big P. And what I think they forgot in that treatise in 1999 was the importance of value, and that's the value to the system. And so that's dollars, it's euros, it's pounds, it's the business case. And the second element was values, the values of the individuals that you're working with, the values of the people you're trying to influence and change, and hopefully the values of those who you're working with. So did they forget value and values? I move then on to the work of Avadis Donabadian, who many of you will know as a health educator, as a health improver, but mainly as an educator. And he adapted a lot of the work from Deming and built that sort of model of if we have the right systems in place, we have the right processes in place, we should improve our outcomes. I think this is entirely relevant to trying to change people's minds in a political firmament. But when we do that, he also recommended, and he felt quite strongly, particularly towards the end of his career in life, was that it was also the ethical values of the individuals within those systems that were as important. It wasn't just having the right systems and processes in place, but it was the ethical values of the individuals in those systems. And we often forget that when we're trying to influence, to move people. We need to try and really address what are the ethical values of the individuals within those systems to try and change them. And particularly, I think, in some of the political movements. And then as many of you who know the work of Don Berwick and others, and Paul Patal, the Duran trilogy of trying to bring a systematic approach into change. Now, we can use this in a healthcare environment, in a business environment, in whatever environments, but it's really looking at those three elements of planning, of control, and of improvement. So designing quality systems in, maintaining what's designed, and creating breakthroughs in the status quo. Politicians are often interested in the latter, the improvement bit, but they often want to see the stability of systems in place before we try and change. So as change leaders, our role then is to try and bring those elements to the core. What's changed, I think, in the last 3 to 4 years is the pandemic, the elements of change that came through from 2019 onwards, and particularly with the devastating impact of COVID across the world. And what I'd like you also to think about in terms of how do we move people, how do we move politicians, in 6 other elements. One is being absolutely transparent in the approach that we adopt. And that's not necessarily being soft, but it's being ruthless in the use of information, appropriate information, and calling people out when they're not in place. So transparency, honesty in our arguments, honesty in what we expect of each other, and honesty in the response. That's often really difficult and tough in the environments that we're in now, particularly in what is considered a sort of a model of disinformation that's moving around. In the clinical world, our patients rely on the fact that not only do they respect the clinicians and the healthcare practitioners, but the healthcare practitioners respect them. And this dual relationship between respect between the practitioner and the patient is equally important when we're dealing with small p and big P in terms of political movements and political individuals. The idea of common respect and equal respect. Without respect, we don't trust each other. And trust is the framework on which patients give us the right as healthcare professionals to work with them, but also we expect that trust and respect from our political leaders as well. And we need to call them out when they don't. What has changed, I think, because of COVID, apart from those elements bringing to the fore, is this consistent aspect of, has there been a change in behavior? Are we treating each other slightly differently since and during the lessons that we learned during COVID? And there are many aspects of how we do and how we don't. What we need to do is build on that element of behavior shift that we exhibited and really move forward. And I think there are 3 elements there that come out in Justin Waring's paper that are really important. And one is collaboration, and the collaboration of effort and the collaboration of teams across pieces. The other one is convening, having sensible convening powers and bringing the right conveners together to enable sensible and improvements to happen. And the third one is ongoing networking. This is a constant element of successful change elements, bringing together networking approaches and networking individuals. I wasn't going to go through Justin's paper altogether, but he brings out those elements of personal style, strategic thinking, communication and engagement, the really important pieces of networking, but also the relational tactics. And one of the things I want to talk about is ego at the moment. Now, what they have talked about in their paper, they talked about ego, and they talked about the ego of the individual. What I want to talk about a little bit is in terms of the actual improvement journey for many systems by individuals is the organizational egos that we have and the systematic ego of the organization. And that's really strong in healthcare. Now, on a small p, I would say as a small p argument, it's trying to get a team together and a team to work and change in in a busy environment in a hospital, or trying to get a hospital to change. That one for me would be small p. The big P is when we're looking at the real national and international changes. I just want to give you two examples, I think, where the absolute importance of ego is there. And one is we developed a national development program for reducing deaths and harms from venous thromboembolism in the UK in the early noughties throughout the second half of the first 2 decades of this century. Now, we did this on the basis, not on the basis that we didn't know what to do to reduce harm and death from VTE, venous thromboembolism. We did it because patients and politicians were clamoring for change. Why were their relatives dying needlessly? The media was picking this up and supporting patients and politicians. But where was the medical profession? The medical profession was way away. The ego of the medical profession was not insufficient in the place to say, we respect your views, we know what to do, let us help doing it. So by a series of changes across the UK, we managed to introduce a whole system or approach, systematic approach to appropriate risk assessment, appropriate prophylaxis, and move the medical profession away from the fact of saying, we didn't invent it here, so you can't do it, to an open system of appropriate risk assessment and appropriate prophylaxis. We're now demonstrating reduction of deaths in that system. The second example I'd like to say, which I've got a half a minute to go.
Oh, okay. All right.
Okay,
Perfect.
half a minute to go. The second element, which we may come on to in some of the group chat, is bringing together an international consortium of approaches through the government, through a series of global ministerial summits on safety and quality improvement. And now we've done that over the last 10 years in 7 different countries, and all systems are working together on this. Lots more to talk about in our group chat. Thank you very much. Thank you.
Thank you,
Thanks,
Mike.
Bill.
No, thank you. And good reminders all around in terms of values-based leadership and evidence-based leadership, not decision-based evidence. We'll come back to that. Susan, you're next up. And Susan is currently, let me get my notes here. Susan's currently serves as president of the Beth Israel Lahi Hospital in Burlington, Massachusetts. And I got to know Susan when she was CEO here at the Royal College of Physicians and Surgeons in Canada while I served on the council. So good to see you again, Susan. Over to you.
Thank you so much, Bill. Lovely to be here today. And as Bill said, I'm based in Boston, Massachusetts. I work, play, and learn on the lands of the Massachusetts nations, of which there's 20 communities that have lived on these lands since time immemorial. And we're very grateful to be here today. I am the president of a large academic health system right now. The Leahy Clinic may be the more familiar term for many that have sought care here in the Boston area. And this is a time of change in the US, without exception. And so as we navigate this time of change and great uncertainty, I have tried to go back and reframe an approach, and I want to share that with you today. And there are 3 components to this framework that I am working and living and using every day. And the first is around recognition and recognizing the challenges and the opportunities that we face. And within that, there will be large P and small p opportunities. Replying or responding to what we recognize as our true north and our true challenge. And then lastly, and I think most importantly, particularly in these times of change and uncertainty, rejoicing, so that we don't lose the joy in medicine and joy in healthcare that we all came into this with, a hope to make a difference. And so those are the 3 buckets that I just want to walk through very briefly. And then obviously we'll speak more personally as we get into the small group sessions. Firstly, the recognition. This is a time of change in healthcare, regardless of the country that we find ourselves in, regardless of whether or not we're in a hospital setting or a system setting, an ambulatory setting, there is change, and that is regardless of what country or region we find ourselves in. Currently, the challenges and the recognition that we have here in healthcare are kind of fourfold. We have to recognize that there will be changes in immigration. There will be changes relative to how we invest and commit to diversity, equity, inclusion. There will be changes in our care, and there will be changes in the way that we provide health care and what the operations and finance look like. So we have to recognize that those are the areas of focus of change here in the United States. And as Bill said earlier, as things happen here in the US, that will affect our worldview and how others feel the changes here. So we recognize that. Most importantly, though, I think as leaders, and I think not only within smaller or larger, regardless of what your leadership responsibility is, we are truly trying to meet the needs of the stakeholders and understand where people are in this change. And so I think if ever there was a time that we should really elevate the LEADS framework, it would be now. Because truly we have to start with ourselves and then work within systems. And so I often find myself going back to this fabulous book that Bill sent to me, I think within 30 days of me arriving at the Royal College 5 years ago. And you know, sometimes you do truly need something to ground you. But that recognition is not only recognizing what will be, but also what will not be. And I think we truly have continued to work through that as the change and our world is very unclear at this time. Lastly, I would say relative to the recognition, I always go back to some of my lean methodology and understanding the failure modes. So to minimize the harm or the effect that any changes might have on those that are least able to respond. And I think as leaders, globally, big P, or locally, small p, we have to recognize the needs of those that cannot respond and be that advocate, be that ally, be that leader. Relative to the response or to the reply that we must create amongst ourselves as leaders, this is where I think true empathy, true understanding, and grace has to find itself. But it's also a response of investment. So I think truly we as leaders have to invest what I say, the 4 T's. We have to invest in tools that will make us be able to care for patients better. The electronic medical record would be an example of that. We have to invest in training. We have to change the way that we teach, the way that we examine, the way that we credential our physicians, our nurses, our colleagues. We have to invest in time, giving people the grace, the space, and the time to make change and make sure that those are cared for. And the last one, which is the most important, we need to invest in transparency. When do we know we are doing a good job? When do we know that we haven't done a good enough job to serve those that we have committed to? Lastly, we have to find some time to rejoice. And that can be at a national level or at a local level, because in a time of change, there must be hope. And I think rejoicing and celebrating, even if they're small wins, as long as they are in a direction of a bigger good, then we have to take the time to rejoice in that. And sometimes as leaders, if only to find the good in all the change is what we need to find our responsibility as we go forward. It may be the most challenging of the framework, that rejoicing, to be positive in a time. But I think as leaders, we have to lift up and hold people up during these times of transitions and change so that we can continue to commit and care for those that need us most. With that, Bill, I will close for now.
Thank you very much, Susan. The 3 R's, rewriting the typical 3 R's, very, very memorable, coupled with the 4 T's. My last name being Thal, and I have 3 siblings. That's 4 T's. And thanks for reminding us that we need to take the time to celebrate success. Many thanks. Now, turning to our third and final speaker, Dr. Deb Basu. Welcome, Dr. Basu, who hails from Pretoria, South Africa. He currently serves as the academic head of the public health medicine at Steve Biko Academic Hospital. Please see his bio, I think, and again, in Grace, in the chat box. And with that, Deb, over to you for 8 minutes.
Thank you, and good day or good evening, depends on which part of the world you belong to. So it's a pleasure to be here, and thank you for organizers for putting up all together. So it is really refreshing sometimes to hear different parts of the world. So following my previous speaker, Susan, so I'm also thinking of the threes, and I'm going to use those 3 points as depicting that what I do as firstly as a clinician, secondly as a public health physician, and thirdly as a health systems person. So in South African context, we use a framework for the healthcare practitioners, and we said there must be the following elements for a healthcare practitioners to practice, whether it's medicine or nursing or whatever. This being a professional, being a scholar, being a health advocate, being a leader and a manager, collaborator, and a communicator. So these traits actually is essential for any undergraduate training in health professional in South Africa. And if you think of my 2 previous speakers, what they mentioned about it, and I think many of them actually resonate very well with that. So let me use my 3 buckets as Susan mentioned it. So firstly, I think as a clinician, I think it is our foremost responsibilities, and we are almost given that whether which part of the world you are getting trained as a health professional, that the patient is the patient in front of you, you have to manage it. Don't look at any other piece. That patient is your most important thing. And obviously, many instances that creates an ambience that, I'm giving an example for if you have a patient in which a very common dilemma we normally face. Let's say a patient who has a HIV positive, and in that case, should you disclose that information to the bigger community? If the patient has a TB, should you tell the community? Because the community he lives, he has a more than every reason to spread the disease. But you have to treat the person, and then you also need to think of the community. That's the second bucket that as a public health physicians we always face. And the third bucket is what the big P we are talking about it. And I think the bigger environment what we are facing. And I think the dilemma between these 3, the patients, the population, and the bigger piece, the political environment that where we all sustain, I think is a major challenge which we face. That article that which we shared with you, I think it talks about number of traits and individuals must have to survive in that environment. That being the personal and interpersonal qualities, that how do we train a person that actually to deal with this type of and complexities that where you have to deal with it. The communication skills, probably, I would say that is one of the most important skills. It's not only with the patients, but your environment that where you survive, the population, and as well as the different political environment that we have to face on a day-to-day basis. It talks about the network and the regional strategies. And I'm going to illustrate my issues with a couple of examples, and then I'll summarize it. So the first being, if you recall, around end of the 1990s and beginning of 2000, our then president Mbeki decided that HIV is not caused by the AIDS, the virus. AIDS is actually, it is a disease or something, and we have that AIDS denialism, which was extremely difficult for us, the health professionals, which we have to manage. And that's where the interaction between the big P, small p comes in, where your politicians or political environment in the country in a complete denialism, whereas the clinicians, the small p in your organization level, you have seen patients dying without any medication. And that dilemma continues for various options. For example, now, very recently, you have seen the COVID pandemic, which my previous speakers mentioned it. I mean, how much of the COVID pandemic was managed as a health issue and how much of it managed as a political issue? I think it is a major challenge that we faced across the globe. Many instances, actually, the lockdown, hard lockdown, and various options, the vaccinations, the availability of the drugs, the practice of medicine, all of them actually influenced by the political environment we work. Obviously, with the current systems and generations and our knowledge, actually, we could manage to share much more rapidly than what we have seen that in early 2000 when we had the HIV pandemic hit us badly in that regard. I think it is the changes, and another example in South African context is the national health insurance. So we are introducing the National Health Service, and I think nobody talks about actually the health part of the health insurance. Everybody is interested about the insurance part of it, and many instances for us is create a huge dilemma because the health part of the health insurance needs to be better understood that it's not just any other insurance because health is an essential and fundamental rights in the South African context, and we feel very proud of it that it is in our constitution. And I think it is the balance of act, many instances what you see, and particularly I think when you see a regime change, a political regime change, that also become very difficult because most of the politicians, the big P, actually trying to influence the smaller p, which is the organization, and to play in their tune, which they promised the moon to their constituencies, and they want the small p, the environment, to deliver. Many instances you see big hospitals being built in many parts of the world, but there is equipments which there is nobody to operate, and but you create an expectation to the population that which we cannot deliver. So coming back to that, so what actually we can summarize and that dilemma between these two P's, and I inserted another P is the patient. So I think one of the things which we should think of at a patient level, that we have a big role to play as a health professionals, that how do we influence the patient, their practices, and their how they behave in many instances, particularly when we deal with the patient with chronic disease, and prevention of many instances actually is how a health professional communicate with the patient. Coming back to the organizational P, I think it is important that as health professionals, we need to influence that how a healthcare organization functions, not just like a business, but there is a bigger issue around a healthcare organization. Obviously, we also have a significant influence in the policies, and which doesn't include only the health policies, but any policies. And I'm a strong advocate of a concept that health in all policies, which I think in my colleagues from Canada probably is very aware of. And actually, it is one of the country which actually successfully implemented in that way. I think it is also important to manage the leadership issues in that regard both at the organization level and at a policy level, at a political level. The clinicians or health professionals at large, I think we have a significant role to play and influence rather than just being a passive recipient in that regard. However, we have to face challenges. In the whether we are dealing with a patient, there are information overload, in an organization level, there are power struggles between the health professionals and non-health professionals, and I think how to manage an organization. And many of this organization carry a significant budget, because if you look at any of the countries with the GDP, a large portion of the health budget actually occupy within the GDP. And my last comment is that, so what can we do? I think it is important to, as Susan mentioned it, the transparency, I think it is critical factor to move forward in that regard. We must be effective communicator, whether we are dealing with a patient or an organization. I think we need to be good communicator. I think the ethical leadership at the end, it plays a significant role in that way. To say that there is a patient or a population or an organization, I think we need to practice ethical medicine, not just follow the tune and dance according to the tune of the politicians. I think fostering collaboration is extremely critical in that regard. And I think to develop a network that where we can talk about it, and the article mentioned very clearly about how the networking can assist to manage in this type of complex environment. And I think we need to engage with the politicians, the policymakers, the advocates, and the regulatory compliance environment that what actually is happening in that environment. So that in a nutshell would be my little contribution to this debate. Thank you. Over to you.
Thank you very much, Deb. Right on time. Perfect. I had a couple of quick takeaways before we put you into your breakout groups. One is that you didn't use these words, but one way to see big P, little p is working in the system versus on the system, something that my colleague Graham Dixon likes to distinguish quite often. And the second one that I picked up is the patient. Again, you didn't put it exactly this way, but the patient kind of being caught in the middle between the big P and the little p for your 3 Ps, and the responsibility that all of us have as leaders to try and address that and respect that. And the last point is all three of the speakers spoke about the need for transparency, the need to step up and stand up when you see misinformation out there, and leveraging up the trust that people have in all of you as leaders.